Good afternoon. I'm Dr. Amrita Gobi from Govt Medical College, Thrissur, final year resident.
I'm Dr. Benji John Varghese, a final year resident, Govt Medical College, Thrissur.
You can keep it. You all are presenting from there, right? You all are presenting from there. No. Leave it. So all the best, and you can start your presentation.
Our patient is Anthony, 58-year-old male, shopkeeper by profession, hailing from Peringotu area. Presenting illness, he presented with swelling in right inguinal region for 1 year. History of present illness. He is a non-case of CAD. He presented with complaints of swelling in the right groin area, which was initially a lemon size, which gradually increased in size over the past 1 year to reach the present size. Patient noticed that the swelling increased in size on straining, lifting weight, and reduced on lying down. He also complains of associated dragging pain. No history of discoloration of skin or the swelling, no history of sudden severe pain of the swelling or discharge from the swelling or any other swelling elsewhere in the body. Effort tolerance good, meds more than 4. No history of nausea, vomiting, constipation, loss of weight or appetite. No history of dyspnea on exertion, chest pain, palpitation, syncope, orthopnea, or paroxysmal nocturnal dyspnea. No history of recent LRT or URTA. In past history, he's non-hypertensive for 8 years on medication. CAD, history of CAD 2 years back, single vessel disease, unstable angina, status post PCI, drug-eluting stent to RCA, now on dual antiplatelet therapy. No history of diabetes mellitus, bronchial asthma, pulmonary TB, CKD, CLD, seizures, CVA, COPD, thyroid diseases. No history of previous surgeries. Drug and treatment history, he is under these medications: tab amlodipine 5 mg OD, tab metoprolol 25 mg XL OD, aspirin 75 mg OD, cloplet 75 mg OD, pantoprazole 40 mg OD, atorvastatin 40 mg HS. No history of drug allergy. Family history, no history of sudden death in family. Personal history, mixed diet, normal sleep and appetite, normal bowel and bladder habits. Ex-smoker stopped 10 years back, occasional alcohol intake. Socioeconomic history, he's from a lower middle class family. Occupational history is a shopkeeper. In summary, 58-year-old male with complaints of swelling in the right groin area since 1 year. History of hypertension on tab amlodipine. History of CAD 2 years back, status post PCI on aspirin and cloplet and on tab metoprolol.
Coming to general physical examination, patient was moderately built and nourished, conscious oriented to time, place, and person. Height was 160 centimeters, weight 62 kilogram, BMI 24.2 kilogram per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Vitals, heart rate was 64 beats per minute, regular rhythm, normal volume and character, no radiofemoral or radioradial relay. All peripheral pulsations felt equal bilaterally. Condition of vessel wall was normal. BP 130/80 millimeters of mercury, right arm in sitting position. Respiratory rate was 14 per minute, abdominothoracic. Temperature was normal. Coming to airway examination, mouth opening was adequate. Thyromental distance 3 fingers. Temporomandibular joint could insinuate 1 finger, and the modified Mallampati class was 2. He had anterior larynx, neck movements range of movements were full, spine normal, no loose tooth, missing tooth or artificial dentures. Local examination, inspection, a globular swelling in the right inguinal region of about 5 into 5 centimeter size, not extending to scrotum. Cough impulse was positive.
So he's described the swelling fully. You don't have to repeat it. Investigation.
Coming to cardiovascular system.
Okay.
Pulse 64 per minute, BP 130/80 millimeters of mercury, JVP was not elevated. Inspection, shape of the precordium appeared normal, apical impulse not visible, no sinus, cast, visible pulsation or engorged veins. Palpation, apex beat palpated in the 5th intercostal space in the mid-clavicular line. No palpable heart sounds, no left parasternal heave, thrill or
Did
other.
you find any positive? Anything positive in cardiovascular?
No, madam. Everything within
You
normal
didn't find it.
limits.
Give your diagnosis.
Diagnosis: right direct inguinal hernia, known case of CAD, status post PCI, drug-eluting stent to RCA, on dual antiplatelet therapy, on regular medication, hypertension, posted for laparoscopic hernia repair.
With hypertension.
Hypertension.
Okay. Okay. Is there anything which you have missed out in your history which is very, very important for you to understand, to plan your anesthesia? You all can, both of you all come here and sit here.
Any signs of stent thrombosis?
Yes. So any history of stent thrombosis. So how will you know? What history you will ask? Because the patient is not going to say, I had stent thrombosis.
If the patient has a recurrent angina or chest pain or fatigue, palpitations, syncope, episode,
So breathlessness,
dyspnea on exertion.
dyspnea on exertion, that's the first thing which they will suffer. Angina, as you said. Sometimes they have sudden cardiac arrest also. So not just that. Also, okay, you said about stent thrombosis. That is one thing. What is another important part of history which you have missed? You said that there was a coronary stent which was placed 2 years back.
Yes.
Is it not important for you to know what stent was put?
It was a drug-eluting stent.
Pardon?
Drug-eluting stent.
Drug-eluting stent. So you have to tell that in your history. Okay. So as anesthesiologists, do you think that we have to know what are the types of stents?
Yes, madam.
Why?
Because we have to
Talk loudly. I don't know whether the last benchers can hear you.
there are different types of stent, and according to that, we have to plan the discontinuation of dual antiplatelet therapy, and the risk of stent thrombosis is different for different types of stent.
Exactly. So you also have to know, as you said, the duration of dual antiplatelet therapy. All that you will decide based on what kind of stent, isn't it?
Yes,
so
ma'am.
what are the kinds of stent which you know of?
We have bare metal stents and drug-eluting stents. And bare metal usually for bare metal stent, we need to for one month we have to give strict and dual antiplatelet therapy. And if we discontinue within that period, there is high risk of stent thrombosis. And in case of drug-eluting stent,
So you just describe what a bare metallic stent.
bare metallic stent is a stent with a stainless steel metal platform. First generation bare metallic stents
Just
with
has a metallic strut.
struct. And
So how long does it take for endothelialization?
usually by 1 month, there is complete endothelialization.
28 days to 3 months.
3
it takes,
months.
right?
And
But
in
what is
case
the problem with these bare metallic stents?
there is restenosis appears early in bare metallic stent, as there is
How do
rapid
you get the restenosis? How does the restenosis
by
happen?
neointimal proliferation.
Yes, there is a neointimal proliferation. Okay, it is a defense because the body perceives that as a foreign body.
Yes.
So there is a neointimal proliferation, and then you can have a stent
Restenosis.
restenosis, right? So that is why the next generation came in, which was the
Drug-eluting stents.
drug-eluting stents. What are the types of drug-eluting? What are drug-eluting stents?
They are a stent with metal strut, and they have a polymer vehicle that slowly eludes anti-proliferative drugs like sirolimus, everolimus, paclitaxel and all, so that this neointimal proliferation is delayed.
It in fact, it inhibits
Inhibits
the
neointimal.
neointimal proliferation, right?
Yes.
That is why they are all actually anti-cancer drugs, if you see.
Yes.
So these are polymers which are impregnated in the metal, right? So do you think you have to know what type of bare metallic stent, whether it is a sirolimus stent or a paclitaxel? What is the difference between the two?
That is a first generation drug-eluting stent. It contains paclitaxel or sirolimus. Second generation has
What is the difference? Why you have to know the difference between the two?
because when we planning for a surgery, if it were a first generation drug-eluting stent, we had to wait for 1 year of a dual antiplatelet therapy. If it is second generation, we can plan by 6 months.
See, the whole thing is the sirolimus has, what do you call? I think it has got rapamycin, you know, which elutes by 3 months, 3 months to 6 months, it disappears, right? Whereas in paclitaxel, only 10% of the drug disappears and remaining 90% remains for life. Okay, so when we come to the surgery, we will discuss this, right? Okay, you said about stent thrombosis. So what are the other patients who can develop stent thrombosis? You know, who are the patients who are likely to develop stent thrombosis? Because that will also come in your history.
A patient who had undergone PCI for an acute coronary syndrome with previous history of stent thrombosis.
Who are the ones who are susceptible to stent thrombosis?
Who are not compliant to
Yes,
dual
one is who are
antiplatelet
non-compliant to the
therapy.
dual antiplatelet therapy. Very good.
Then some, there are rare cases they have resistance to antiplatelet therapy.
Very good. So there are some patients who have genetic polymorphism where they have resistance to P450 enzyme, right? So they are the ones who can have
stent thrombosis.
stent thrombosis. Who else?
Then certain, if you are taking certain medications like NSAIDs, proton pump inhibitor, that can also inhibit the antiplatelet action.
Which other drug? Which are the common drugs?
Omeprazole, then
Not omeprazole.
NSAIDs.
Antifungal drugs mainly, like itraconazole, then erythromycin, NSAIDs can, right? Patients who take too much of grape juice, right? All these are susceptible. Plus, most important, you have forgotten, those patients who have diabetes, hypertension, renal disease, low EF,
chronic renal failure.
Yes, all these are the patients who are very susceptible to
Stent thrombosis.
stent thrombosis. Very good. Okay. So, so you said dual antiplatelet therapy. So you will give, what is dual antiplatelet therapy?
Usually we give COX-1 inhibitors, aspirin, along with P2Y12 inhibitors like clopidogrel.
Okay. Clopidogrel is what?
Irreversible P2Y12 inhibitor.
Okay. Then?
Then we can give...
what are the other antiplatelet drugs you know of?
Reversible P2Y12 inhibitors.
One is thienopyridine group of drugs where you have clopidogrel. Then you have acetylsalicylic acid group of drugs where you have aspirin. Then in thienopyridines you also have one more drug which is
ticagrelol, cangrelol, reversible P2Y12 inhibitors.
Clopidogrel and ticlopidogrel.
Clopidogrel, prasugrel.
Yes. So how is prasugrel?
Both are inactive. Their active metabolites are actually inhibiting the P2Y12 enzymes. And
prasugrel is a more potent drug. It acts longer. Okay, and it is given to those patients who have these clopidogrel resistance. So this is the drug of choice for patients with clopidogrel resistance. The other drugs, of course, you know, is 2B3A inhibitors.
CP2B3 inhibitors.
They are what? Tyrifobin and eptifibatide, abciximab, all of them, and dipyridamole. Okay, these are the various antiplatelet agents which we know of. Okay, so you said you are going to give dual antiplatelet therapy to these patients, right? So, for how long you will give in a patient of bare metallic stent or in a patient of drug-eluting stent? How long will you? You have to know this in your history. In your patient had undergone 2 years ago, so you have no problem, right? But it may not be the case every time. You can have a patient who had a stent placed 6 months ago, 3 months ago, you know, a stent placed, 10 months ago, coming for, say, Whipple surgery, coming for an orthopedic, fracture femur. You can have any kind of patients coming to you, right? So then drug-eluting stent, for how long will you give?
For
Dual
6
antiplatelet
months
therapy.
to
6 to
1
12
year,
months.
we must give dual antiplatelet therapy.
At least 1 year.
1 year.
At least 1 year. Okay, there is one more, presently we have one more group of
Biodegradable
Yes, we have a biodegradable
drug-eluting
stents.
stents.
What is the advantage of these biodegradable stents?
After 1 year, the stent struct will degrade by itself, so that
It
the
will be absorbed.
absorbed,
Bioabsorbable stent, you can say.
so that the normal vasomotion will be preserved. And
Yes. So, and this dual antiplatelet therapy is given for how long in these patients?
for 6 months
Up
to
to
1
6
year.
Up to 6 months. 1 year is for all these
Drug-eluting
drug-eluting patients. Okay, so is there any test which can prove this endothelialization in these patients?
CT coronary angiogram.
Will you do a CT angio before hernia surgery?
No.
But are there any tests to prove? CT angio will prove that there is endothelialization? Will it prove? You said that, but will it prove? It won't.
Endovascular ultrasound.
There are no tests to prove endothelialization, right? Okay. So, why are we so worried about dual antiplatelet therapy? Why are we worried? Why are you talking so much about it before surgery?
We are worried about the stent thrombosis as well as the bleeding risk
Bleeding on one side,
and the
because you're
thrombosis
giving
on
dual
the other side.
antiplatelet therapy, and thrombosis on the other side. Why are you actually worried about thrombosis?
Perioperative.
Just before the surgery, we are, the patient is coming for surgery, and you're not just worried about bleeding, but you're also worried about thrombosis. Why?
Surgery itself is a
Prothrombotic state.
Very good, yes. So what happens with that? What happens with the stress?
Already the myocardial oxygen demand is increased.
It's an increased
Oxygen.
inflammatory state. It is a procoagulant state. Isn't it? Surgical stress itself can incite so many cytokines. There is fibrinolysis. Isn't it? Also the stress of you have just stopped your dual antiplatelet therapy before surgery, and an immediate stopping of dual antiplatelet therapy, you can have a rebound thrombosis. So that is why we are worried about, dual antiplatelet therapy and surgery when you're looking at both together, right? So that is the reason. All right. Okay, now you have, the patient is now posted for surgery, right? And now, exactly, now this, in your case, it is a hernia, isn't it?
Yes, sir.
So what would be your recommendation in this case? It's a 2-year-old patient. Patient is only on baseline clopidogrel of 75 milligram aspirin. Patient is on beta blockers. Okay.
It should be advised to stop clopidogrel 5
And
days back.
also the fact that patient doesn't have any chest pain. You know, see, one important thing which you also forgot is when they did the coronary angiogram, you're supposed to see the angiogram to see if there are any residual any blocks on with the other arteries. Many times the cardiologists, when the patient comes suddenly for an acute angioplasty, they do only the culprit vessel. They leave the other vessels alone. So, which means here is a patient with residual ischemic heart disease. So you have to know whether there is disease in the other vessels, right? Because that disease could have progressed, right? So that's again a very important history, and which you have to elicit, which you have to see and elicit in these patients. Also, if there are, bifurcation lesions, these are the patients whom you have to worry, So there are certain things which you have to know pre-op itself. And your patient has a good EF, all well, but you can have a patient with a poor EF. If the patient has poor EF, again, there is lots of reasons to worry because these are the patients who will go into heart failure. That is one part. And the second part is these are the patients who can have quick stent thrombosis. Right? So these things you have to be very, very, what do you call? Okay, now you're coming to your case. Your case is a case of hernia. So how are you going to go about the case?
I will ask the patient to stop clopidogrel 5 days prior to the surgery and ask to continue aspirin and also continue metoprolol. Then I will ask to do all the necessary and relevant investigations, basic investigations like hemoglobin, platelet count, coagulation profile, blood sugars, electrolytes, renal function test, ECG, and chest X-ray. And
you said everything except except that you don't know what is the function of your platelet, whether your platelets are
bleeding time, clotting time.
Isn't it?
Yes.
So you will also do a 2D echo again on this patient to know the heart function here. Okay, even though it is a lap hernia, you still have to do a 2D echo to know the background of how his heart is functioning. Okay. Also, you have to know the platelet function. So what are the tests which can determine platelet function?
Impedance
aggregometry.
Pardon?
Impedance
Start with the poor man's test. No.
Bleeding time, clotting
Bleeding time. Bleeding time is first thing. Then what else? Then you talk about all these big tests, which are
light emission aggregometry,
platelet aggregometry, yes.
and impedance aggregometry.
Okay.
And
what about platelet assay?
thromboelastogram with platelet mapping.
Okay. All right.
Rotem.
Then
verified test.
What about the use of TEG? Madam spoke about, Lakshmi Kumar Madam spoke about TEG, right? Can that give you anything about functionality of the platelets?
If the maximum amplitude is above 47 millimeter, platelet is hyperactive. And if it is less than 30 millimeter, it is activity is less.
So yeah, if you have a low MA, then you know that you're looking at a dysfunctional platelet, isn't it? Okay, so a TEG can also help you to a certain extent. Okay, so so you have done your pre-ops and you want to take up the patient. So now you have to give advice. How are you going to advise
On
your
the
patient?
pre-op day,
Your patient, I'm not talking about your patient. I'm going to talk about a patient who had a stent placed about, say, 6 months back. He comes for an obstructed hernia. Obstructed hernia, right? It's not because if I tell you hernia, you will say you will postpone the case, right? Isn't it?
Yes.
You will postpone the case, and you're right. You're not supposed to do the case with the hernia can wait.
Since this is an emergency case, we have to proceed to the surgery after clinical risk stratification. And I will plan for general anesthesia.
No, you have to tell me what you're going to do with your dual antiplatelet therapy. It's an emergency surgery.
Yes, ma'am.
Even if you're going to give general anesthesia, you still have to think about dual antiplatelet. So your choice is going to be general anesthesia, and I agree.
There is a risk of increased bleeding, so we have to arrange platelet concentrates.
So will you look at the platelet count?
The count may be normal, but its function
actually,
affected.
Okay.
Then we can do a platelet function test, like bleeding time. And based on the platelet function test, we can transfuse platelet concentrates.
Basically, at this point of time, the TEG will kind of give you some guide of how much of platelet concentrates you have to transfuse. Usually, a single platelet will increase the platelets by how many?
15,000.
15. Single unit,
5 to 10.
about 5,000. Right? If it is an SDP, it will be around 10,000.
10,000.
Okay. So you find that the MA is reduced in this patient.
Then
So what you will do?
Then I will transfuse platelet concentrates.
How
and,
much?
So that there is
give
50% of platelet activity.
Okay. See, platelet number and function both can be reduced. Okay, if you're giving general anesthesia, at least 50 to 60,000 should be your platelets, and your bleeding time should be normal. Okay, or at least 1 to 1.5 times, increased. But you can guide your. We have only 1 minute more. 10 minutes. Oh, okay. So the guide to platelet transfusion will be based on your TEG.
Thromboelastography.
Okay. Otherwise, as I said, if you don't have TEG, you go by your bleeding time.
BPCT.
Simple bleeding time. Okay, but that's not scientific to call it. Okay. Then general anesthesia, you'll have to tell me exactly what you want to do.
I visit the patient on the pre-op day. Since it's an obstruction, it is coming as an emergency.
My dear boy, your patient is a case of ischemic heart disease. Okay, and he is having a stent in place, which is only 6 months old. So if you're giving general anesthesia, you have to follow certain rules of how you're going to give general anesthesia. What are you going to do about it? It's a lapse surgery, right? So what kind of anesthesia you're going to give? What are the drugs you're going to choose? What will be your anesthetic consideration? All that should come here.
My anesthetic.
Okay, now I'll give you another clue. What are the, what do you call, what are the conditions which play with the coronary demand and supply?
Conditions which increase some oxygen demand include tachycardia, increased preload, increased afterload, increased contractility, increased wall thickness. Conditions which decrease oxygen supply include those which conditions in which there is decreased oxygen content, and also there is conditions where there is
Anemia.
decreased. It can be anemia or hypoxia
tachycardia.
or ODC left to shift side. Conditions which decrease the oxygen supply are tachycardia, hypotension, especially decreased diastolic BP, increased preload, and coronary vasospasm, and hypocapnia.
So you will ensure that you will maintain a balance, right? So maintain proper heart rate, you'll continue the beta blocker. Patient is already on beta blocker.
On beta block.
Right? Okay. Then what is your plan for general anesthesia?
I will premedicate the patient.
Now, what is your anesthetic? What
Govt.
type of anesthesia? That is Madam asking. Is it controlled ventilation, spontaneous, intubation, supraglottic, like that?
General anesthesia with controlled ventilation with the cuffed or an endotracheal tube.
Why you don't want to use a second generation supraglottic airway?
Since this is a laproscopy, there is an
You can't use?
increased risk of aspiration.
It's a short surgery. It's not like 4 hours.
Proceed LMA if available.
Can use.
Can.
Rather, the response is also less. Like the hemodynamic response is less with supraglottic airway devices. So you can use, but if you say endotracheal intubation, you're not wrong. I'm not going to say you're wrong, but don't say that supraglottic airway devices cannot be used. You can use it. Rather, if it is used, it reduces even the hemodynamic stimulation, right? It reduces that, and which helps in ischemic heart disease patients. So you can use it. Okay, then?
We'll premedicate the patient with IV midazolam 0.02 mg per kg and injection fentanyl 2 microgram per kg IV. And in the pre-medication room, we'll attach all the monitors and we'll start the oxygen therapy via simple face mask, low flow oxygen therapy. And from the pre-medication room, initially we make the patient comfortable by making a rapport with the patient. Relieves us, we have to take care of his anxiety, and from the pre-medication room we'll shift the patient to OT in a trolley, oxygen trolley, and in the OT already we have to set the OT, we have to check our workstation.
All that you have done, what are the monitoring you will do? What induction agent you will use? Standard
ASA monitor, ECG, pulse oximetry, non-invasive blood pressure monitoring, and post-induction ETCO2 monitoring.
In which patients you will step up your monitoring?
For
in your patient, you will do standard monitoring of non-invasive blood
if the
pressure.
ejection fraction. If the ejection fraction is less than 40. And if patient is having NYHA grade 2 for dyspnea, if the METS is less than 4, right, and multiple other comorbidities, and very recent history of very recent MI, acute, then
Very good. So step up means what you will do?
we'll put a pre-induction invasive arterial BP monitoring.
Central CVP?
CVP. For this case,
Will you do CVP or no?
Yes.
the trend, it's not
Pardon?
absolute
no.
value.
If
Is
it
not,
is going to be a case where you're going to have lot of hemorrhage, you definitely, most definitely have to have a CVP monitoring. Otherwise, no. Okay. So here you have a case of a hernia where you have done general anesthesia. Supposing it is a planned case, patient is coming, say at 1 year. Okay. So what will be your plan of, taking the patient? Say about 10 months, say, I'm not saying 1 year. How are you going to do the, what do you call, how are you going to stop the drugs and take up the patient?
Sorry for the interruption. The time is over for the session.
Okay, I'll just give you the answer. So you have to stop the drug by 7 days, right?
yes.
And then if there is a need, you can do a bridging therapy. Bridging therapy, earlier we used to talk about unfractionated heparin, but it has been proven beyond doubt that UFH does not help. Neither does low molecular weight. So it's a tirofiban infusion along with UFH, which should be given, which can be stopped 6 hours
6
before the
hours prior to
surgery.
surgery.
And then restarting should always be as early as possible. Dual antiplatelet therapy restarting should be as early as possible. One more point which I want all of you all to take is, if you can avoid epidural, please avoid epidural. Okay, and if you have to give regional anesthesia, give a platelet infusion just before the regional anesthesia. And in this case, if you want to give pain relief, you will give a tap block.
Tap block.
Give a tap block,
NSAIDs.
right? That you can safely give on these patients. So,
See, I heard you were mentioning clopidogrel resistance. What's the reason? What's the reason for clopidogrel resistance? You mentioned, isn't it? What's the
There
reason?
can be abnormality in CYPs the hepatic enzyme abnormality which convert the clopidogrel into the active form.
Because clopidogrel is a prodrug, right?
Prodrug.
In some, this particular isoenzyme is missing. So in them, there is resistance and there is a chance of stent thrombosis, as
thrombosis.
Madam mentioned earlier. So in them, you need to go for other drugs which are
Prasugrel.
directly acting.
Prasugrel.
thank you. I think they did a fantastic job. Give
Thank
it
you,
up.
madam.